Okay, thanks everyone for joining us. We are expecting around 100 people a day, but I think we better kick it off now. Thank you all for joining this community of practice, the second in the series, hosted by the Health Innovation Northeast North Cumbria and the Renal Network in the Northeast North Cumbria. Just some housekeeping before we start. Please do keep your microphone and video turned off during the session, apart from our speakers. This will avoid this disruption and any interruption with the speaking. If you need to take a break, please go and do so at any time. Please note the event is being recorded and PDFs of the slides will be shared after the talk. If you want to see the recording, you can do so after the event when it's shared on Eventbrite. In fact, as I'll go through in a moment, you can see the previous talks as well. And I do encourage you to do so. If you can't see the chat or if you have any questions, Phil, who is running the slides for us and doing a tremendous job of organising the slideshow, will be able to help you. Next slide, please. Thank you. So the agenda. Obviously, we're in welcome introductions right now. A slight change in the agenda is that it's actually Dr. Rupert Major, not Jim Burton, and he'll be speaking first because of time pressures in his work being on call. So he'll be first, followed by Dr. William Hinchcliffe, followed by Barry Todd. And then we'll speak about the wider community of practice and any other business and close. So that's what we'll be doing today. So just to recap on this community of practice, the reason we're really doing this is to really showcase the fantastic work that's going on in this region and beyond in the rest of the country around CKD management, early treatment, prevention in primary care. Really getting to the heart of stemming the rise of end-stage kidney disease, stemming the rise of dialysis, etc. And that really links in with those three shifts that the government and the nation now has of driving from analog to digital, from hospital to community, and from treatment to prevention. So that's where we are. So the previous community of practice had some fantastic talks by Lorna Howie, who presented the RADAR information system. Fantastic resource that's available to every GP practice in the region. Can show you your key statistics and performance. Please do check it out. Equally, Tim Ringrose of Cognitant presented on the fantastic Healthy Note system that is available to our entire region for free for patient education. Again, please check that out as well. You can see that during the talk from last time. And finally, Dr. Lynn Sykes, consultant nephrologist and AKI lead for the Northeast North Cumbria Renal Network, spoke about AKI management in just generally, but also post-discharge and for primary care. She also discussed the digitised inter-hospital referral system, ConnectNenc, that is in our region, and to my knowledge is the first case of a whole region being digitised in its inter-hospital referrals. And potentially one day, who knows, maybe even from primary care to secondary care, but we'll have to keep an eye on that one. So lots of exciting things coming along in our region. Next slide, please. I'll very briefly give you a recap of the resources available to you right now. If you were to go to the Health Innovation website, you'd be able to see things such as the CDRC case finding software that each and every one of you in your primary care practices can use to case find, code cleanse patients with CKD and other conditions. Instructions are on there for use with EMIS and System 1. And some useful guides, etc., and other resources that you can find for primary care, CKD, and other forms of management, so it could be CVD, etc. as well. Next slide, please. Equally, we in the Renal Network have a NHS Futures page, which you can join. It's open entry to any NHS staff. You can join that. You can see case studies. You can get links to various different resources, some produced by people on this very call. And also you've got things such as public engagement campaigns, the Bloody Amazing Kidneys campaign by Kidney Care UK, fantastic national programme. And also, as I mentioned before, the Healthy Note patient education system, online, multilingual, avatar-based, really easy to understand, and just really pushing that education to the population. Next slide, please. So now I will hand over to Dr. Rupert Major, who's done some fantastic work in Leicestershire and Rutland. Rupert.
Thank you very much, Alex, and thank you for the invite. And yes, Alex, as Alex said, we've been navigating the strikes. I'm sure that many of you have been, and I'm also on call, so I've ducked out briefly. So if I suddenly have to answer my phone, it's not because I'm being rude, but I will try and stick with you for the Q&A session at the end as well for any comments. So I'm going to be talking about some work we've been doing in Leicestershire and Rutland. That's our ICB. We've recently clustered with Northamptonshire, so we're now an ICB of approaching 2 million or so people. And this all started around about the first wave of the pandemic, so looking back to the days of 2020. And it's a piece of work called the Leicestershire and Rutland Chronic Kidney Disease Integrated Care Delivery Programme, and is now business as usual in our area. So I'm hoping you will see the slides moving on there. So declarations wise, Lucid was part funded by AstraZeneca UK, who are the makers of Forxiga or dapagliflozin, but also Lokelma, the potassium binder. So for those of you in primary care, you may be less familiar with Lokelma. But it's a potent potassium binder used for management in people with more advanced kidney disease. And that was between April 23 and November 24, but we're now, as I said, business as usual. I want to give a brief overview of Lucid, and I've already heard some of the examples that you've given of projects going on in your area. And then I wanted to compare and contrast some of those, but then also to start to think about how can you make this business as usual. Pilots are fantastic. Having 18 months of support from an industry partner was absolutely brilliant. But ultimately, if we didn't then shift it onto something that we were doing day in, day out, it was unlikely that we'd have a long-lasting impact on care for people with kidney disease in our area. So as I said, it all started way back in those horrible days of the first wave of the pandemic. We didn't have a vaccine. We didn't really know where we were going with this. Would COVID be around forever? Would we be socially distancing forevermore? But we started to think about how we were delivering care differently. So as I'm sure many of you were, moving to more virtual telephone-based appointments, how could we deliver care in a different way? At the same time, for those of you more familiar with the management of CKD, the kidney failure risk equation, which we had led in Leicester, had been put in the NICE guidelines. And so we were thinking more generally about education in relation to that and how we could talk to people about risk stratification for kidney disease. And so our ICB at that point gave us a small amount of funding of around about £10,000 to develop some patient education videos, and they're still available there. They've had 120,000 views. Now they've been featured on the Kidney Care UK, amongst other sites. And those education videos were everything from what are your kidneys and what do they do, all the way through to you've got a kidney transplant, what do I do with my immunosuppression? And so we tried to cater for a broad range of needs within those videos. We've now incorporated them into patient letters and those sorts of pieces of things as well. We developed in collaboration with one of our patient volunteers as well. And so the core ones around this at the time were about using SGLT2s more as well. So that was one of the core pieces of work we did. So the ICB were very happy with that. They thought this was a good, impactful piece of public education. And so we started to think a bit more about what we could do and develop things. And we started off really as much with enthusiasm as anything else, because at that point there was no money for us to develop this. And so we started to go out to some PCNs that we knew for other reasons and try and deliver virtual care in those settings. So using Teams, sharing System 1 where we could to look at patient records and delivering those MDTs at a PCN level in with collaborators in primary care. And we started off very much in a slightly dictating how this would go. We'd come along, all the GPs and nurses and pharmacists would all sit down and they would all listen to how much the nephrologist knew about CKD and how knowledgeable and brilliant we all were. And we soon realised that that wouldn't work. So we started then to think about other ways to deliver this sort of care, thinking about how MDTs might be delivered with people dropping in and out with single queries they might have as they went along. and how often these should be. So was monthly frequently enough for these sorts of meetings? Did people want them more regularly? So we started to deliver that around some of the early detection pieces of work, early intervention. I've already mentioned SGLT2s, and we'll come on to some of the other medications we've got data on as well. And so we started this in April 2022. This data is published. In fact, what you're seeing on screen is more up to date than the publication there. But you're very welcome to look in that publication for more details about what we've done. So in April 22, we started off without any funding and started to deliver this for around about a year to 4 PCNs it grew to. And we started to see some patterns. So after about 300 or so of these interactions with these PCNs, we started to see that about 50% of people we could deliver medicines optimization, advice around ACEs, ARBs, advice around SGLT2s and those sorts of things. About 40%, 45% of people we didn't change the management, or we felt there weren't any changes to make. And what we started to discover was that was actually really powerful. It empowered GPs and the pharmacists that were delivering these meetings that actually they were doing the right things for a lot of their patients. It also allowed us to reassure patients that they didn't necessarily need to come to hospital. They already had the right care in place for their GP team, and I think that was perhaps one of the elements that was found to be most useful in those early stages. An early observation was also that this was going to be some sort of ruse to not see patients in hospital, to bounce referrals back into primary care. But the data's actually shown that for every person where we give advice and avoid a referral into secondary care, we start to pick out those higher risk patients as well. We start to pick out the people who are at high risk of progression or might need a kidney biopsy, those sorts of elements as they come along. And so, as I mentioned at the very beginning, the funding from the industry partner AstraZeneca started in April 23. That's where the vertical dotted line is on the screen there. And we saw a very, very similar pattern as we expanded across different PCNs. So we've now seen well over 3,000 of these contacts. Again, we're seeing similar patterns of people who are able to provide optimization, medicines optimization advice, to similar patterns of referrals avoided versus referrals expedited on that. For those of you who work in the area, it won't come as a surprise to you, this slide, but nonetheless, I think it's useful for people who don't have the clinical background, particularly when you're talking to commissioners, about the fact that many of these people also have the common comorbidities that we know come with kidney disease. So 80 to 90% of people had hypertension, 50% of people had diabetes, and about 20% of people had heart failure as well. And that was useful as we start to think within our ICB about a more cardiorenal metabolic approach as to how actually seeing people with CKD almost gets you to that point to start off with. And I think where we really add value here is as people's kidney function drops, being able to give advice on things like diuretic titration, which diabetic medications need stopping or reducing in dose, which can be safely used for that as well. So I think that's where we add the additional value to the wider cardiovascular metabolic area. Now, of course, it doesn't really matter if all we can do is sit there and say, yeah, this is a great idea, we're all really enjoying this, we're all learning a lot, we think it's a benefit to patients. Of course, if we don't have the hard evidence to deliver that, then that's probably unlikely to lead to a business as usual situation. We were fortunate enough to have some funding from the Health Innovation Network locally for ourselves to have an external evaluation of this that was performed by Edge Health, and their analysis of those first 4 PCNs showed the results that for every pound invested in this scheme, the return was about £2.75 per year, and that was a combination of improved management of people in primary care, changing the referral patterns, but also the nice evaluated impact going down the line of dialysis and kidney transplantations around the use of SGLT2s. The piece I should add now around this is that because the SGLT2s have become generic, the benefit to cost ratio is likely to be even higher, because the vast majority of this, the costing of this was that cost of the medications, and we know the price of those has already dropped by about 60% and will probably go lower. The overall figure for the ICB, if we'd rolled this out fully, was thought to be just under £500,000 a year. Again, I would suspect that will be higher now that we've changed with that. So what we've also tried to do is think about ways we can scale the intervention as well and make it as easy as possible to pick these things up and develop them in their own area. And one of the pieces we were keen to develop was how we used open source data. And again, this has recently been published, the QR codes in the bottom right corner there, but it shows finerenone prescribing rates for our area. So if you're not familiar with finerenone, it's a novel agent for type 2 diabetes for people with CKD, and is thought to reduce the risk of progression of CKD. As we know, new medications rollout is a real challenge as well. But what our data has shown using open prescribing data is the purple line there, showing when it was approved locally, the prescribing rates for where Lucid was active, for the yellow line in the non-active areas. And I should say finerenone in our area is amber, so it needs to come through a consultant nephrologist to be prescribed. And we can see there's a statistically significant difference in the prescribing rates for finerenone in places where Lucid is active. I'm just going to run through some practical tips for this as to how you might get to the point where your business as usual. So yes, you can start small and be enthusiastic with a minimal amount of resources, but ultimately you will need some resource to start delivering this. AstraZeneca have expanded the program into something called Lucid Accelerate that will support the further rollout of Lucid or Lucid similar services in other areas. So please get in touch if you want to make some contact with them. Ensuring primary care is adequately resourced to deliver this is absolutely vital, and we did underestimate that, so I can perhaps give a full another talk around that. But look for the quick win as well. Get the attention of the ICB. For us, it was those videos we did very early on as well. So in terms of the wider idea about reflection and how we've innovated. So if we innovate, we're going to make mistakes. We have made mistakes in the costing and how we're going to deliver that. So please do talk to other people who've delivered these sorts of services. One size won't fit all. How we deliver Lucid in certain practices and certain PCNs does dramatically differ. And so try and come up with a solution that will work within existing work programs for both primary and secondary care in your area. Collect a mix of data, but remember, you're not running a clinical trial. I'm an academic by background, so I tend to think in terms of collecting the perfect data set to make the evidence as robust as possible, but that's not always feasible when you're running a quality improvement project and developing a new service like this. Talk to the key decision makers is vital as well. If you've got some good news, email your chief executive, email your chief medical officer of your ICB. They want to hear good news at the moment, so don't be afraid. And I'm not naturally somebody who goes forward and tells everyone how great we're doing. But so for me, it was a challenge. But people want to hear about good news, and they will try and support where they can. They may not be able to offer money, but they can offer support in other ways as well. And that's where this piece comes into it. So have you identified your stakeholders to get this to the point of business as usual? So do you know who's got a lot of influence in the system and will be highly interested in this? So they're going to be clearly vital people. Do you know who's got influence in the system but is probably going to be less interested? Now, I put our finance department in that area. They've got a huge amount of influence, but they're probably not interested in kidney disease. So how and why are you going to sell that story to them as well? So reflections on what we've learned just in the last couple of minutes. So don't reinvent the wheel. Share your resources. Alex has already given you a great example at the beginning there of the resources you've got available locally. We can share any of our analysis, external evaluation. We can share business cases for this to allow you to deliver the program as effectively as possible, without having to spend days and weeks and months developing the program again. Things that I thought mattered that don't. Project management, absolutely vital. And I know that's difficult at the moment. The ICBs are reducing headcount. So that is a real challenge, but the importance of a project manager is so vital to this sort of thing. I also think branding is important. Again, I wouldn't have admitted that before we started, but being known as Lucid is far more effective than being called the Integrated Chronic Kidney Disease Programme. Lucid is now recognisable. It's the ICB can see how they might convert Lucid into other programs like CVRM, like respiratory, to gain extra support as well. I briefly want to touch on the Eclipse dashboard. This is a service that we use, and for those of you in primary care, you may already be familiar with this. This is a prescribing safety tool. We've developed a Lucid dashboard within that to allow us to look at the key areas, the high-risk patients, the areas of people for medicines optimization. Now, the advantage of this is that it's already available on multiple ICBs. So if you're in any of those ICBs listed, you could have access to that resource without having to build it again for yourself. And that will give you a starting point. Where are we performing as a excuse me, where are we performing as a practice or a PCN across the ICB? And where might we want to focus on for our early areas of improvement, so that you can show those quick wins, those early changes that will allow you to gain some traction for your project. So again, I can share some more details around that if anybody is interested. And I would reflect on this final piece, which is particularly if you're looking at a system level within an ICB, it's often easier to get on board the innovators in your area, the people who are prepared to do things differently and won't necessarily worry initially about the money. But often where a lot of innovation falls or drops back is in between these two areas. So those people who are the innovators, the early adopters, want to try and do things differently will get on board with you. And that was probably our core 4 or 5 PCNs within our ICB. But then later on, you get people start to become more pragmatic and skeptical about what you're doing. So how are you going to engage with those areas? How are you going to, first of all, identify those innovators? How are you going to engage with the early majority in that group? Often it's about reassuring people. So there was a lot of concern about how we would increase work for people in this area, how we would decline referrals and expect more management in primary care without the resources. So you need to understand and acknowledge those concerns when you're looking about scaling and doing things differently with this as well. So I hope that's been of help to yourselves. I'm happy to talk in more detail about Lucid and can share all the resources. Again, in terms of establishing your business case, we have lots of resources available that we can share business cases around how Lucid is set up. AstraZeneca, amongst other pharmaceutical companies, are looking at how they can support further rollout of these sorts of programs. So again, please do get in touch if you want to discuss that in more detail. And again, the QR codes are at the bottom, including our patient education tool, My Kidneys and Me, that I haven't even had a chance to mention at all today. So yeah, thank you very much for your time, and I'll happily share the slides at the end of the session because they're slightly different to the ones on Alex's slide deck. Thanks.
Thanks so much, Rupert. That's absolutely amazing. And like you say, it's fantastic to hear good news stories, because don't we all know that the country needs it right now? So fantastic stuff, Rupert. I think we've got time for 1 or 2 questions, or we will have the bigger session later. William?
Thanks, Alex. Yeah, thanks, Dr. Major. A great. I think it's a fantastic model, and I definitely think it's the way that we go forward in the grand scheme of things. Just one question about reduction of referrals that you'd mentioned, and the reduction of kind of advice and guidance. Have you had any pushback from surgeries, particularly with the change in advice and guidance now being funded, and also that advice and guidance sometimes can be a little bit quicker than referring it to an MDT?
Yeah, absolutely. And again, I would just, if you're thinking about this sort of program, I would reflect on what your own infrastructure looks like. So advice and guidance in our ICB, and I didn't realise this at the time, is very well established already. So whilst yes, the incentives to use it have been there, we've not seen a significant difference in that, and we've never talked about switching off advice and guidance or any of those concerns. So absolutely, people have still got those existing ways to refer in. if they don't feel it can wait, they can refer in as usual into advice and guidance or a standard referral. We don't in any way try and inhibit that. But actually, what we've seen is we develop those personal relationships. So the pharmacist in one PCN who runs Lucid for their area, if she's got a concern, she'll email or ring me now, and she's got to the point where her skills have developed that I know if she rings me, then we probably do need to see the patient. And so part of it is about building those relationships with colleagues, so they're very happy actually just to ring up in between meetings, and I think they respect that access is a great thing to have, and it's not abused or overused or anything like that. So I think that's been something we didn't expect to happen, but it's been a really great thing as well.
That's great, thank you. And I think that's like that's the good thing about this kind of secondary care and primary care working together. I think that's where we need to be, really, don't we? Thank you.
Fantastic. Yeah, a great model that hopefully will, with the current pressure for the 3 shifts, which you've been doing before it became fashionable, Dr. Major. I think that hopefully we'll see that natural progression of the entire population of primary care, secondary care in lots of different fields, hopefully. Sorry, now to move on to Dr. Will Hinchcliffe from our own region. Hello, Will.
Hello. Thanks very much, Alex. I'm going to talk for about 10-15 minutes here as well, and if there's time for questions immediately afterwards, we can do that. But I will also be on at the end as well, if or with or without Rupert, to answer questions, because there are lots of unknowns as well, equally in CKD, particularly around generic guidelines for different patients. And within this deck, there will be some also contentious points, perhaps a bit more, I'm maybe in Rupert's group of that I would call myself slightly innovative, trailblazy slightly with some of my ideas. And as you've heard from or know from the CKD Hack series, I like to keep things very brief and get it direct. So the title of this presentation is trying to reduce upstream cardiovascular disease via prioritizing CKD interventions, i.e. indirectly. And Rupert's already alluded to the CVRM panacea in all these particularly obese diabetic patients where the comorbidities coexist. So Alex has also covered why this is always needed and always relevant. The 10-year plan is that to get into the community, to keep people at home and move things digitally. But equally, there's some other reflections as to why I've done this pilot work, and I've been wanting to do this type of thing for around 4 to 5 years, but it's not always possible depending on the priorities in different areas. And equally, as Will Burles in the questions there has said, it's primary, secondary care have not traditionally worked that well together in a renal sense. So if you could try and find the patients upstream, then there's more chance of trying to reduce downstream flow, and I'll allude to that as we go through the deck. But it's certainly most effective when started early, and the greatest benefit, as I'll show you on a graph in the next few slides, is to reduce time without kidney failure, and we know that people with kidney failure die from cardiovascular disease. But also, as Rupert's also mentioned, there is some downstream benefits from screening people that are at the highest risk, particularly on RAS blockade or add-on therapies, because they do experience hyperkalemic events, and hospitalization rate is much higher. And this is relevant to my current practice as I move to direct clinical care, being acute medicine in May, from a 10-year tenure as a consultant kidney doctor in Sunderland. So I'm now in County Durham, working at UHND. But also, there's no point in trying to do things by yourself. You've got to upskill and leave legacy where you can. And that's another thing where secondary care has not been particularly proactive in nephrology when you compare us to diabetes or heart failure services, for example, where there is a wide community footprint of ologies, where there has been embedded practice in place rather than a siloed way of working. And you've got to choose where you're going to do your work. So why did I choose my initial pilot as Claypath and University PCN? Well, it's a single practice, so therefore the politics are easier, and there is a digital vanguard as clinical director for that with an ICB role in Northeast North Cumbria and Mike Smith. And we've had rapport over a long period of time related to mutual care of kidney patients in County Durham, that was my patch. And I've been given the time in my job plan to do this, so it's not sponsored or industry funded, which was also a novel aspect. So it's an add-on to my day job, and I've got an honorary contract to deliver this work through the PCN as a GP registrar would do, and I have all systems access to the primary care suite. I'm going to move the slide next just to tell you and reinforce that, of course, all the CKD trials showed cardiovascular benefits, and they weren't unique to any product. This is SGLT2 inhibitors across people with or without diabetes, initially Credence, then DAPA CKD, then EMPA kidney. And this is relevant because if we start therapy early, then we can delay time to RRT need by up to 15 years if you are on a Flozin and a RAS inhibitor and you start at the highest levels of GFR. So this is how we find our patients to target. You also know what the needs are, and this is also relevant for targeting where you're going to do your work. And Alex mentioned radar as a proof that we can try and find where we need to exert our energies and manage resource. For example, here, County Durham, this is all Flozin indications, so diabetes, heart failure, look at the maths. There's still poor penetrance, but it's not bad at 30% across all indications. But when you look at some practices, Derwentsside, Gareth Forbes up at Ledgate is a leader in digitalization and implementation with the founder of CDRC. He's up at 50% there, but Claypath, where I directed my energies, is lower. But it's a different cohort with a predominantly student population, so the numbers are expected to be more modest and meaningful when you're looking at pilot work. So on to the meat of what we did. Well, there's these three searches that exist within CDRC suite called CKD intervention prioritization searches, and they are very clever, and there are at least 12 different searches which run continuously and look at prioritization for people with CKD. So this isn't necessarily coded CKD. This is people based upon lab results, microalbuminuria levels, etc., pulled from their System 1 records. And there are three different priorities, and the highest risk score is a composite of the number of different features that need escalation. So a person with CKD4, for example, has 2 points automatically, but doesn't become 4.1 if no intervention is needed. However, if they have at least 2 interventions needed, they're likely to get into 4.3. 4.1, that should say, rather than 4.3, and you get the gist of things. The score equals the number of interventions plus the baseline CKD, so it's quite a nuanced system, and I think unique compared to some of the tools out there for prioritization. However, you need to be mindful about what you're going to focus on as far as your areas and the population that you're going to target, because equally, as we've seen from Rupert and Jim's work, the numbers are vast and you need a lot of resource behind you. I'm N=1 working into the community to try and demonstrate that tools are available to leave you with manageable workloads, because I think that has been an issue with any recommendation or teaching that we've given to primary care, that where do you start? The scale of the task is vast. So if you look at why people die as they get older with different levels of kidney function, and if you look to once you're over 75, it's clear that you're more likely to die than reach end-stage renal disease, even at quite low levels of kidney function. The BNF also recommends that we use Cockcroft-Gault for EGFR rather than CKD-EPI, which is the default reporting tool. And most people's life expectancy is still only just above 75, depending on the year that they were born in County Durham. So we chose to only analyse up to age 75 from the patients that were identified in this search. And this is where I said it is contentious, but equally I can try and give you some other reflections as to why we had to, or we thought this was the right line to draw. There's an uncertain number needed to treat because many of the patients in these large flows in trials and MRA trials were not in that at this age group, above this age group. And even with diabetes and cardiovascular disease as prevalent conditions to CKD, their relative risk of end-stage renal disease doesn't increase much, and I'll show you that on the next slide, based upon a tool that we recommended in the CKD Hack series on Medscape, that actually if you look at a 75-year-old with a GFR of 25 and an ACR of 25, their actual risk of death doesn't go up, although it doesn't go up that much, even when you add in cardiovascular disease and diabetes, for example. So just to give you some idea of that. And also we're going to try and go towards prevent to try and model cardiovascular risk a little better than we're currently doing with QRISK-3, because it doesn't take into account microalbuminuria, and I think there are lots of people that are perhaps overlooked. What did we try and do to map out a process? Well, this is how it might work on the left of the screen here as to how we're identifying patients in those different categories and then trying to manage the flow of work towards a ologist via targeting their annual reviews, which typically falls within their birth dates for primary care, to then offer them appointments for investigations, for example, to contemporize their risk scoring from albuminuria, GFR, lipids, and then trying to then provide commentary. And you can look at different tools to map them against. This is a cardiovascular disease template within System 1 and the CDRC template, but I know that Rupert and the guys from work with Niraj have their own template that they've developed as well for CKD. This is what we looked at. This is the lowest risk population that we've got here, where we've got, these are the interventions that were offered using this template into System 1 for their next annual review, using this pros section here with a direction towards myself for commentary for the clinicians that we're next likely to see the patient in their annual review. And this work is not being submitted to UK Kidney Week, but the premise has been, and I'm going to submit it to ERA, which is in Glasgow. Both of these big meetings, thankfully, falling in the Great North, so to speak, this year, well, next year. So we hope to try and collaborate with as many people from across the UK and Europe as much as we can into next year from this work. It gives you some idea about the section and the spectrum of interventions that are offered. And likely, and this is the lowest risk population. If you look at the highest risk groups and the medium risk groups, you'll see that the themes are typically lipid lowering therapy, RAS inhibition, and a fair amount of increasing recommendation here following the FLOW study. Obviously, this is in diabetic patients and those that are at the higher weight spectrum with albuminuria following the FLOW data. However, this hasn't translated through into UK guidelines as such at the minute. However, based upon CVOT surpass with tirzepatide, hopefully things will follow. That was American Society of Nephrology data recently to support that as a recommendation. So you give us some idea about what. One thing that surprised us was that there was very little recommendation for finerenone use. Rupert showed that incident prescribing went up with the use of Lucid, but actually I didn't find any of these cohorts within ClayPath and PCN that needed or that were eligible for veneno and Arden as it stood. This may change, of course, as the investigations come forward and interventions are offered, because it is an add-on therapy for diabetic microalbuminuria. We built some templates to send out to patients to try and empower them and direct them to CKD understanding, and therefore understand the medications that are being recommended by their clinicians. So I'm going to wrap up just there, and I have abridged this presentation to make sure that we didn't eat into too much time, but I've got some hidden slides for questions and answers to back up some of the things that have been said. But as you'll see here, I'm not going to read this verbatim because many of you know all these statements, but it is time that we try to work into primary care and develop a community nephrology model, as Rupert has done, and as this pilot shows that these tools are realistic to try and deploy on the ground at a PCN level. And I'll be moving on to other PCNs after the pilot year finishes with ClayPath, and then where the numbers are expected to be bigger. But thanks very much, and thanks for the invite as always, Alex and the team. Thank you.
Brilliant, Will. I think we absolutely do have time for one or two questions. Any questions from the audience? It's really interesting, Will, what you're doing, like bridging that gap. Like you say, doesn't often happen, does it, between primary care and nephrology to that extent, as has been done by yourself, by Dr. Major, and course. So I suppose, would you say that an important thing you mentioned at the beginning is that you've been given this time in your work plan to do it? Do you think that is a key element? Because too often it's down to just goodwill, isn't it?
Yeah, for sure. And I think, you know, there is drop off in advice and guidance because the clinicians will come directly to me, but it's tricky working into primary care because the climate isn't easy. They're all overworked, but that's why I've gone in to offer the services, because it's clear that, you know, despite the game changes that we've got, that there hasn't been traction, and there's lots of other data on flows in use in the UK, internationally. As we know, microalbuminuria, I think Barry's been a zealot for taking the P campaign. That needs to improve to actually improve detection. So although this work isn't focused on increasing detection, it's complementary to programs that are going on, such as Spot CKD, to actually drive the flow of patients towards these intervention tools, because we need to make things manageable, because there's a lot of people that have already got CKD and have been left on the shelf and are you know, still left on the shelf, and that's where we're trying to play catch up for.
Absolutely. Just a quick comment from the comments from Philip Stubbs. Not a question, but that Medscape hack is very helpful. I'll put the link in the chat, and possibly see you in Durham, West PCN at some point, Dr. H. Yes. Brilliant. William?
Yeah, thanks, Alex. I just want to quickly point out, actually, I'm very interested in the fact of the upper limit being 75. I think anybody who's run any kind of CKD project will find that the numbers, as Dr. Hinchcliffe has said, are out of control in some sense. And obviously, you know, we're in a time at the moment where there's a lot of younger patients living with comorbidities, and they're living with them for longer. So it makes total sense to be risk stratifying these patients and kind of targeting those younger patients a little bit. So I think that's really interesting. That's quite a, you know, an interesting takeaway that from that project. So thanks for sharing.
No problem, Will. It's bold. I realise that, and ageist in some regards, but the GPs that I've worked with equally were agreeable to it, because they're all pragmatists. They have to be, given the management of resources. And you've all been in difficult consultations where you're discussing initiation of statins in people that are, you know, rather old, and it's the numbers needed to treat aren't necessarily applicable. And we have nice guidelines that gives us a one-size-fits-all for atorvastatin 20 in everybody with CKD, but for many of these people, they've got marginal CKD based upon a GFR of 59, for example, with no microalbuminuria, and therefore the risk is, difficult to have a counselling discussion with. So if you try and streamline, or minimise those awkward conversations, it makes your workload more manageable. And this we'll be moving to some of the KDIGO recommendations for statin initiation, and trying to use the other cardiovascular tools to predict risk, certainly in G2, A2 CKD, because I think that there's a lot of people that aren't well served by the one size fits all from NICE. So we'll be trying to add that into the hack in the 2026 iteration.
Fantastic, thanks, Will. So last but not least, Barry Todd, working in Wallsend.
Hi there. Thanks very much, Will, and thanks very much, Rupert. And just great work that you're doing in Durham and Leicester. Great work being done in Gateshead and in Sunderland and Tees Valley. And I think that is the way forward at scale. But we're not all privileged to be part of these big projects. So to use Blue Peter terminology, this is something that you can do at home. So my question to you really is, could this be something that you could take on to make a difference in your practice or in your PCN for your CKD patients? Every project needs a driver, and could it be you? So our project, I'm not going to spend too much time telling you what we did and the results of that. So we'll keep that brief, and I want to concentrate really on lessons learned and legacies left. So our project, we started really well upstream with patients who didn't even know they had CKD. And we used the CDRC tools to identify patients who had CKD but weren't coded and didn't know it, and those patients that might have had CKD according to one reading, one low eGFR or one high albumin. And then what we did was, having confirmed and coded those patients, we engaged with them, and we told them about CKD, that they had it and what that meant, and invited them to a patient group consultation to learn more, to empower them, and then to go on to then optimize them on appropriate medication. So we're talking about a PCN of 43,000 here, and an engagement with AstraZeneca in order to provide some money to do this with. We also use a third-party interface, clinical services, to do some work around diabetes with CKD and the initiation of SGLT2 inhibitors. Next slide, please. Great. And so, I'll just move on to the next slide. And the next slide. So what we did was we actually were able to move our prevalence of just over 4% across the Wallsend PCN to 4.7, just over 4.7%, by identifying 330 new CKD patients, which meant essentially that they were now on a register, that we were able to do something about them. And then we could, we moved our prevalence more towards the national prevalence, estimated national prevalence rate of 6%. Next slide. And we're going to send this slide deck out to you if you want it. You can have a look at the results, but there you see a sort of 50-50 split in terms of lipid-lowering therapy interventions. That was either giving them a statin or at least offering them a statin, or adjusting their dose. We offered ACE inhibitors where appropriate, and ARBs, and there you can see there's a higher rate of acceptance than decline. And in the small proportion of patients, remember we're talking about new CKD patients well upstream, only very few were eligible for an SGLT2, and out of the 11 that were, 8 accepted. So remember that the threshold for non-diabetic intervention of these agents is higher than in diabetes, of course. Next slide. We invited 181 patients to a patient group consultation to tell them about CKD, to empower them, to educate them, and only 33 actually attended. So that's an 18.2% attendance rate, which apparently is a par for the course. So next slide. And next slide again. Next slide. And next slide. And next slide. Lovely. Okay. So lessons learned and legacy left. So the first thing that I would say to anybody who is wanting to do some sort of project within their practice or their PCN, and you need some money, would be to see what's out there. Previous projects I've been involved involved a grant which gave me carte blanche how to use that money, really. But in this case, there was quite a few criteria or stipulations that AZ laid down, including timescales in terms of and really what we did, interventions, and we did feel a little bit constrained with that. Obviously, any money is good to help do the work, but perhaps knowing what I do now with the joint working agreement, probably you need to stick your heels in a little bit and negotiate a bit harder as to what you want to do rather than what they want you to do. What we didn't have is we didn't really plan for a lead into the project. We had 6 months in order to do this, far too short a period, and it took us 6 weeks to find our feet. So I would suggest that if you do go and plan a project like this, that you do factor in some learning time, just so you can get a feel for your patients, a feel for what you're doing, and to be able to, because you'll not be able to, unless you've got expertise previously, it's a big learning curve and you may not be able to hit the ground running. We found that we had limitations in terms of our technicians. We had our technicians going through the CPPE primary care scheme, and this was their first exposure to real clinical work, and they found it difficult. It took them a long time to get up to speed as well. We should have been a bit more strategic, as we've already heard. A strategic approach will give you some low-hanging fruit. What we did was we just went in there and we did a lot of work trying to establish whether patients had CKD with one reading, repeating it, and either confirming it or refuting it. A lot of fruitless work there, and and it led to low morale in the team. So we modified that and went to the more likely patients as we moved on. And also plan well for your staff. There was an imbalance between using our pharmacy technicians to reach out for patients initially and the pharmacist work to be able to do the medicines optimization and the patient group consultations. So we had to draft extra help in along the way. So take that into consideration. And remember that you will have staff absences, especially if you're doing something over a holiday period, such as we did over the summer. So next slide, please. And I would say also that patient engagement clearly remains an issue. Don't be disappointed if you get low numbers when you try to reach out to patients. With our patient group consultations, we had a very high satisfaction rate, and patients were very happy with the care that they got afterwards. Although retaining the knowledge, or at least how to manage CKD, did decline over time. We did some evaluation work as a follow-up. But those patients that didn't engage perhaps felt as though that they were frightened with the terminology of CKD. They maybe wanted to speak to the GP rather than a pharmacist, and maybe they didn't want to go to a patient group consultation where they would be discussing personal issues in a group rather than as a one-to-one. But we did get CKD back on the radar. Notice RADR there. We've already mentioned the use of the radar tool. But CKD isn't funded through QOF, and it is a Cinderella, or was a Cinderella condition. We now, everyone's aware of it in our PCN. Everyone knows what to do with it in our PCN. And it's led to a lot of upskilling, not only in our pharmacy team, but also in the clinical team across the board. We have learnt that CKD, although it's one of those terminologies that strike fear into the hearts of the patient when they first find out about it, especially if they find out about it inadvertently through a hospital letter and they didn't know they had it, or so on, then we were able to meet that, explaining what CKD was over the phone, and to take the sting out of it, but at the same time saying that this does matter, and therefore come along and find out more. So empowering the patients and providing the medicines, and also we should reduce cardiovascular events in our patients and delay the decline into end-stage kidney failure. Next slide, please. So the legacy that we've left, we believe that we've put a clearer pathway in the managing of CKD in primary care. We've learnt to communicate CKD with our patients and have encouraged people with more other healthcare professionals, practice nurses, healthcare assistants, and even GPs to articulate CKD better to the patient. We are wanting to reinforce the CKD message at every opportunity. We've adopted a cardiovascular renal metabolic approach. We, instead of just preventing, we've gone on to perfect and encouraging quick movement to the maximum tolerated dose levels of our medications. We have tried to get people to ditch the old way of coding CKD and adopting the new coding with using the albumin. This has met with a little bit of resistance among GPs because for them it's more work, but we've tried to underline the utter vital importance of doing that. We have advocated urine ACR testing for everyone with diabetes, type 2 diabetes, and hypertension. So that's been adopted, and we would love to see it with occlusive vascular disease as well, and perhaps even heart failure. We have been encouraging people to chase up missing urine ACRs, and one thing that I want to do as a legacy is to provide a way of actually identifying patients who haven't had a UACR, who've been in to see the nurse, who have forgotten to take a urine sample in, been told to bring one in but haven't. We are going to have a look at that, see where the gaps lie, and perhaps the use of our care navigators to reach out to those patients to give them another reminder to bring a sample in. We make more making sample bottles more readily available at reception desk to give an empty bottle for a full one as patients bring in urine samples. We will be engaging in the Taking the P campaign, which Health Innovations North East North Cumbria are piloting at the moment as a patient education tool. And I'd like to have a look at the significant number of SGLT2 inhibitor dropouts, why patients have started but aren't continuing on with the SGLT2, because that is a very cost-effective intervention in terms of health economy, and it's good for the patient, but there is significant dropout rates. I'd love to know why, and that's a project for the future. So that's kind of about it, really. Any questions?
Great, thanks, Barry. So I think that you've seen a fantastic range of talks today, and Barry, that's brilliant. Like the grassroots work you've managed to do and lessons learned. Then, as you've said there, hopefully people on this call and those who come to watch the recording can learn those lessons and not have to go through the difficult parts that you very much have had to wade through to get to the really good parts. So any questions for Barry? So Barry, so if there was just one take-home message for the group, what would you say?
I would say plan well.
Plan well.
Plan well. Really do stratify your patients, because you probably won't have the resources. So if you want to do something, do look at your high-risk patients, CKD with diabetes, CKD with hypertension, and that's where you'll get the most benefit from. We tried to do an all singing and all dancing, really, and it didn't really work. So we had to sort of change our strategy part of the way through the project. Yeah.
Fantastic. But Barry, as you've shown, you've managed to completely change the mindsets. You've really improved the entire attitude towards CKD in that PCN, which, as I've mentioned to yourself, Barry, was the PCN, as it was the practice I went to as a child. So it's got a lot of relevance to myself. So just to very briefly update you all, I know we've gone over a little bit, but I'll just let you know about the upcoming events. So the next COP, so Community Practice, will be Thursday the 15th of January. And there we plan to have the following speakers: William Burles, who's asked some questions today, clinical pharmacist, on the Spot CKD project, which is going on in Sunderland and in South Tees, but he can speak from the Sunderland perspective. Dr. Ian Logan, who is a consultant nephrologist at Newcastle Hospitals, hopefully will be speaking to us about SGLT2 inhibitors. And Kaylee Bramley, senior clinical pharmacist on the FACT CKD project in Gateshead, which has also been very kindly funded by AstraZeneca. She'll be talking about that project, which is now closed. So much stuff that's going on in our region, going on nationally. The wheel has been invented. I think we just need to put the cart together, which I think is a terribly butchered analogy there, but I think the point is made. Other upcoming Hyneng events. So if you ask Phil Kyle via email, he can let you know via the bulletin if you want to sign up to that bulletin to get regular messages on other conditions, other communities of practice, and just really trying to get best practice out there throughout the entire region for our patients, really. So I'm happy to stay on for a little bit longer if anyone wants to ask any questions. If our speakers don't, if you're in a rush, I appreciate you'll have to go. But if you don't mind answering any last questions, we'd be very, very grateful. So any last questions for any of our speakers? Chris Gray.
Thanks, Alex. Thanks, everyone. It's fantastic to hear that today. I guess not a question really for speakers directly, maybe just more for the community of practice, but taking a sort of view, not necessarily just of renal either, but it relates to renal of research. The North East's quite often one of the areas of the country that receives a lower investment in research from other areas of the country, from industry. And I just wondered if it might be a sensible topic in the future to look at opportunities for research within this renal space. So more of a suggestion rather than a question, really.
Absolutely, Chris. Our region does, as you say, get, like you say, very low investment generally. I think when you compare us to the likes of London, despite the fact that our population is very deprived and suffers from a lot of comorbidities and a lot of socioeconomically linked issues. But I think that's a great idea, Chris, and we can discuss that, how we might get that out to the community and how we get some ideas and cooperation on that.
Will Hinchliffe rather than Burlace on this occasion. I'm happy to present on that. Chris and I have spoken about different projects that are ongoing. So maybe in the March meeting, if you put me down, Alex, I've got, I'm lead local investigator for easy kidney at PCN level, and there's other stuff going on with cardiovascular, but also stuff on the horizon with AZ and a couple of other sponsored commercial.
So can I ask why generally does our region get left out so much? Why are our region's patients so left out of these things? Is it just down to the hospitals, or is it down to making patients aware? It's just one of those unknowns.
I think nephrology has always been very secondary care, and I think as you've said, it's like unless those hospitals are very research active or depends on their national reputation as to where they might attract sponsored commercial studies. Chris would probably agree with that. I've been known some of the guys down in the southeast, and I think the further up the A1 you get, sometimes we become less attractive. Certainly, it's difficult because a lot of these studies you do need site visits. You've got to transit samples. Say, for example, Easy Kidneys set up at Oxford. You've got to send samples down there. And that increases overheads, for example. Some stuff, most is investigate, managed locally, investigate locally, and run through the local labs. But there is other stuff that does need to be taxied down.
Yeah. Well, thanks so much, everyone. Any other questions before we close? As I've said in the chat there, if anyone has any ideas for future talks, as Will and Chris have just suggested there, I will put you guys down for March. Thanks very much. Any other questions, or shall we close it there?
Yeah.
I do appreciate we're over time. Thanks everyone for joining us from around the region. Thanks to our speakers, especially for giving your time to speak to us about your fantastic work. I think we covered so many different areas, from organisation at regional level, secondary and primary care integration, and primary care engagement with patients and patient education and the challenges therein. So I think it's been brilliant. Will?
Alex here. Just wanted to say I touched on UK Kidney Week. It's in March in Harrogate, so just an hour down the road from the northeast. You can get there and just even attend for the day. And then, as I said, ERA Glasgow in June. So equally, that's only 2.5 hours up the road. And there's a lot of good CKM, CVRM, CKD stuff going on in Glasgow, certainly in community academic primary care hubs. They're also worth networking as well with, and that's the north.
Absolutely, very rare to see so much activity in the north, so let's take advantage of it. Thanks so much, Will. Thanks everyone, have a great week.